Let's make a complete assessment specific to a psychiatrist or an APRN that's working in an inpatient psychiatric facility. From the patient's chart face, we're going to click this button, Complete Assessment. You'll be taken into the History of Present Illness tab. We're going to be working left to right across each of these tabs. The workflow is going to be left to right across each page of the program, and it's a top to bottom workflow. We're only going to click on buttons that are relevant for our patient and skip the rest. Let's take a look and see how this might work. So you're given an opening sentence. Blythe is a 61-year-old woman. Her chief complaint is, and I'm just going to make it real short. Once you've put in the chief complaint for the patient, you can come over here. The buttons that are in the gray field here are hardwired buttons. They open up into shrubs, and you're going to be able to generate full sentences into the program. The program has the ability to put 30,000 sentences in without you having to touch your keyboard. Let's come over here and look at symptoms, and I'm going to start with depression. We're going to work in our depression shrub area. It's going to open up left to right, and we're going to add some details. Information about this depression was given to us by the patient and also by the family. You can type in additional details anytime you want. Husband Jeff. Let's come over here and talk about the history. Is there a precipitant for the depression? If no precipitant was described, you can simply click here. If the patient did give you a precipitant for the depression, you could say there is one described and come down here and pick divorce, for example, or legal problems, or a pending divorce, or what have you. What has the speed of onset been? And your patient says it's been insidious over the past couple of months. When depression occurs, the patient says it's chronic. You might ask the patient, have you ever been depressed before? She says, yes, I've had one prior episode of depression, but I've never been manic. What current symptoms is the patient telling you about right now? You skip the ones the patient doesn't have and you just document what the patient tells you. They have a lack of energy, they're having anhedonia, fatigue, and sleep difficulty. Patient, are you suicidal? The patient says, I have ideas but no intentions of actually committing suicide. You could type in additional details here. You're also invited to use these custom buttons that appear on every page of the program. I've made up several sentences relative to suicidal ideation. Let's pretend like she's Catholic. I'm going to click this button, suicidal ideation Catholic, and it puts in this nice sentence. Blythe says, I am Catholic and would never really want to harm myself. Okay. Notice that it's picked up her first name so that the sentence reads true to her name. These buttons appear on every page of the program. They're under your control. You can create new buttons, you can rearrange the buttons, and you can edit the buttons. If you'd like to learn more about how to make a custom button, please go to www.ICANotes.com, select the Support tab, and go to the training videos on the first page that you open. As you scroll down on the lower third of the page, there are 2 training videos specific to making custom buttons. When you make buttons in the program, they show up for all of your patients, not just for the patient you're working on today. So the more buttons you have on each page of the program, the more you'll be able to pop in information that's specific to what you would like to say about your patient without doing additional typing. Let's come over here to the center column and talk about the severity or complexity of this patient, and I'm going to select high right here. It gives you a nice little sentence here. Blythe's severity is estimated to be high based on the risks of morbidity without treatment and description of interference with functioning. So you sort of covered your bases in terms of inpatient treatment required. There's all sorts of other options that you could go into. I invite you to explore those. You can look at current stressors, symptom behavior reviews. If your patient is abusing alcohol, we have a chemical dependency button right here where you can document that for a dual diagnosis patient, for example. You can also link to the ASAM rating scale and have it display after you've worked through the 6 dimensions within your initial assessment. The red X's mean that you've already worked in these particular fields. To do a problem pertinent review of systems, I'm going to say she denies having an eating disorder and she denies OCD. You can do a review of other body systems. For example, if you want to document that the constitutional and musculoskeletal systems are normal, ICANotes will do that for you with a click of a button. If you want to say that all other systems are also normal, you could click here. Or if you wanted to do a detailed review of other body systems or just pick out one system where the patient might be having special trouble, you can come over here, and I'm going to say she's got an endocrine disorder. There's an abnormality, and it has to do with her thyroid, and she's hypothyroid, and I've documented this right under my history of present illness because I think her hypothyroidism is negatively impacting on her depression, and I'm going to say otherwise negative. Now, of course, I could have documented this in the medical history tab as well, but since I think that this is really having a negative impact on her depression today, I'm going to put it right up here in the history of present illness. Okay. Let's come down here and talk about entering test results. In our program, if you order something like a metabolic profile and it comes back completely negative, don't go into this button and document all of the negative test results. It will take you a lot of time, and basically the best way to handle that is to have that lab result scanned to the desktop of the computer and uploaded into the documents folder under the labs for the patient's chart. Well, you'll be able to look at them that way. Reserve this area when you want to document abnormal lab results that you want to show in your note and you want to be able to see in a log and be able to trend over time. Plus, any test results you manually enter into the program are going to push out to your final discharge summary without you having to come up with them. So it's a really nice way of capturing the high and low points of labs during the patient's stay and not having to remember them at discharge. You'll have access to this button from your progress note as well. Let's come in here and take a look. I'm going to click the new button and I'm going to come down here and I want to look at chemistry. Maybe we've got, let's say here, blood alcohol level, and it came back abnormal, 0.2 to 0.3. You can type in additional information here if you want to, and then you can just click the save button. I'm going to come down here and look maybe for a lithium level. I like to trend medication results in here, psychotropic meds. So we've got a lithium level today and it comes back at 1.0, and I'm going to save that in here knowing that it will show up on my discharge summary. Let's say your patient, hematology, everything looks fine except for her platelet count, which is running quite a bit low. It's at 120,000 or maybe it's 125,000. Just know that you can, it says 120, but you can tweak this to say 125,000. And click save. So you can stack up as many med results here as you want to. Go back. And now let's just pull the scroll bar down. And you can see all of those test results. Actually, they're showing right here. Right here. Okay. We're going to come over here to the past psychiatric history. This is the first note that's ever been created for Blythefeld. If this had been a readmission, or if the nurse in your inpatient setting or the social worker had done an initial assessment of their own first, information that they capture under the history areas, past psych, medical, social, developmental if you're working with kids, family mental health, would be shared in these areas for you. Likewise, if you're the first person clinician in here and you're doing the past psych history and medical history and so on and so forth, when your colleagues do their initial assessment, anything you've put into these fields will be shared with you. We do this as a courtesy. If you don't want a medical or a psych history in your note that was entered by a nurse, feel free to erase what the nurse wrote and just come in here and enter your own. But the idea is with EMRs, this is supposed to be a collaborative effort. A lot of facilities assign tabs by clinicians. So the past psychiatric history is done by the psychiatrist. The medical history is actually saved for whoever does the medical H&P. Social history is done by the social workers. So each member of the team isn't having to go into each of these individual areas. That will be an individual workflow that you'll have to discover with your lead user. I'm going to take you through each of these. We're going to really focus on the physician or psychiatric side, past psychiatric history, and I'm going to talk, if there's withdrawal history, you can capture that. Patient, have you been hospitalized before? Yes, I have, more than once, and you could put down the name of the hospital. I could have that down here as I could actually turn this into a colon. Let's see what happens here. It's been a while since I've made this custom button. Blythe has a history of previous admissions to Wake Medical Center in Raleigh, North Carolina. Okay. Have you had outpatient treatments? Yes, I did receive. And the condition that was treated was depression, and this was treated by a physician or a therapist, and this occurred when the patient was in their 40s, and the length of the episode lasted for several months. Notice that I've got a lot of options right down here to the bottom, just to show you guys when you come down. If your shrub goes all the way to the bottom, scroll down because you probably have more options hidden under the horizon. Was medication prescribed? And I'm just going to say no, there was no medication prescribed for that particular event. Have you ever been suicidal or self-injurious? Yes, I've had suicidal attempts. The patient says, I've tried to hang myself. I've also had self-injurious thoughts. Okay. Have you been assaultive, substance abuse? If your patient was a substance abuser, it would be better to come back in here and go into the chemical dependency area to capture that in full detail. Just want to point that out to you. You can talk about acting out behaviors, medication compliance. This should be specific to psychotropic meds. I'm going to say there is a history of noncompliance. Psychotropic medications, as psychiatrists, you can detail that we had them all here, we think, from Abilify through Zyprexa. And you can detail how the patient tolerated them. So, for example, if your patient had been put on Buspar in the past, you could come over here and you could say, the patient says, oh, I stopped Buspar. It was not effective for me. Plus, I don't like taking psychiatric medications. So you can be able to drop that in. But maybe the patient says, Celexa. Actually, I have been taking Celexa, and I've been taking that for about a year. And my current dose is, I'm just going to type in 20 milligrams. For example, and then you could put down whether the patient is compliant with that or non-compliant using a custom button, and I put down compliant. Okay. We have a button here. If the patient fails monotherapy, you can go in and explore that, and we have a button down here that says otherwise the past psychiatric history is negative. Medical history, if you're in a facility where you don't have somebody doing the medical H&P and you need to grab this, it's really straightforward. I'm going to just show you the key features. Infection or disease. This is where you could document about TB skin testing and chest x-rays. If the patient has an infection or has been treated for, let's say, is HIV positive or MRSA positive, let's say they're positive for MRSA, despite being treated for 3 months on vancomycin. HIV is in here too as well. Here we go. HIV AIDS. There is a current infection with AIDS. Details are as follow, and you would add your own details. Or make custom buttons specifically to HIV and be able to push those in. You can capture a past medical history, past surgical history, adverse drug reactions. Oftentimes in the inpatient setting, we like the nurse to capture this on admission. Typically, they're in the chart before you are, so this would probably already be done. But in the event that it is not, let's go into a list of adverse drug reactions. We don't have any listed here. It's a top to bottom workflow. This patient, it's an active adverse drug reaction to sulfa. You do have to put a reaction date. You can use the calendar or you can click unknown. One or the other. I'm going to say this patient had a respiratory event and had respiratory distress. I could type in more details here if I wanted to. Click the Save button, and this adverse drug reaction has been added. We'll go back into our medical history. Just so you know, in ICANotes, allergies are food allergies, not drug allergies. I'm going to say peanuts causes wheezing, for example. Current medical diagnosis. Let's say that your patient has a seizure disorder. Come down the center column. It's alphabetized by body system. I'm going to neurological, and I'm going to go with seizure disorder. And then current medications. These are the patient's non-psychotropic meds. I'm going to come down here to neurological. I'm going to click Dilantin. And I am prepared to say that my patient tells me they're non-compliant using that custom button. I already have another button ready to go for a non-compliant patient with a seizure disorder. I have a button that says my last seizure was, Blythe says my last seizure was last week. Whoops. So you can see how as you make these buttons, You can build prompts into the program that are going to save you a lot of time as you use the program more often. If you're working with a female patient, reproductive history is where pregnancy is at. This is probably something that you want to talk about. I'm just going to say she's not pregnant, but you could drill down. We have a nice pain scale in here I invite you to take a look at. And we also have a cardiac disclaimer. There's no family history of early death due to cardiac arrhythmia, conduction defect, or other related cardiac issues. Let's go forward into the social history. It says here Blythe is a 61-year-old woman. The areas that are down here are really more relevant in the inpatient setting to the social worker that's assigned to the patient. I'm going to draw your attention up here to this high-risk psychosocial behaviors. As a psychiatrist or the nurse practitioner heading up treatment of this patient, you might want to come in here and take a look if something drops in that makes sense for your patient. For example, elopement. If this patient is at risk for elopement, then you could go ahead and document that here if it hasn't been captured already. The other area, the other button that I like is family negativity perhaps is present and you feel puts this patient at risk for noncompliance with your mental health services. There's other options down here that you could use. For example, violence. This patient has been assaultive and has injured others, for example, or has homicidal impulses or a history of destruction of property. You're invited to put in your details. You can add more information. Okay. The other areas that are down here I said are really you could do it as a psychiatrist. We're not saying you can't go in here. I'm going to take you into just one or two areas that I like. One is coping strengths. So we're not just talking about negative things about your patient. I'm going to say your patient presents as intelligent, verbal, and is also artistic. You can talk about their home and their family, and if they're having gender or sexual identity issues, we have shrubs for all of those areas. We also have something down here for trauma history, I just want to point out to you. So it kind of starts off with the typical things: automobile accident, military combat, sexual assault, and all the way down here to terrorist attacks or natural disasters, or maybe they have a life-threatening illness. Developmental history, you can fill this area out in terms of gestational developmental history, whether it's negative or if there were pregnancy complications or developmental history issues if you're working with minor children. Family MH is mental health history, not medical health, just so you know. And let's come down here and say that Blythe has a sister who completed suicide by drowning. She also has a grandmother who was hospitalized for bipolar disorder on the maternal side of the family, and a cousin who was thought to have also bipolar disorder on the maternal side of the family. And then you can finish up by saying otherwise the family mental health history is negative. Mental status exam. If you're watching this video and then you're going to go on to our progress note video, the mental status exam is identical in the two different types of notes. It's a top to bottom workflow. As you're capturing information, the program is sort of tallying this here. This is useful if you're doing evaluation and management coding in the program. That's actually covered in another training video that you can look at from our website as well. But we're going to come over here, and just so you know, you can actually get through a full mental status exam. It would be 11 bullet points in about 30 seconds once you get really good on the program, and it doesn't take long to pick up that kind of speed. I'm going to start with appearance. It's broken into 3 areas. Starts with, continue with, and end with. I usually pick 1 or 2 from up here, 1 or 2 from here, and then end with one of these guys down here so that you don't have a sentence that's long and rambling. Instead of saying our patient is depressed, let's come in here and document a mental status exam relative to a patient that's manic, for example. So I'm going to say that this patient is, I'm going to come down here and say irritable, inattentive, distracted, and we have some options down here, but they really don't fit my manic patient. So I've made some custom buttons, and I'm going to say and intrusive. So you can make custom buttons to end one of our hardwired sentences over here and to really further detail it very, very quickly. If I do that, I want this to be the end of a sentence. I put a couple dots ahead of it so that I know, oh, these buttons over here go at the end of my appearance area. Let's come down here and talk about speech and language. They are not normal. When you go into the C list, you get a series of signs that you can document to. I'm going to say that she is pressured, she is garbled, she's poorly modulated, and she is loud in volume. And then maybe her language skills are just fine. Come back here. Her mood is not depressed, she's not euthymic. I'm going to come into elevated. I'm going to say she's severe, she's distractible, irritable, labile, pressured, and tangential. Let's come over here and look at affect. Her affect isn't normal. Once again, I'm going to go into the C list, and I'm going to say she has inappropriate smiles and inappropriate laughter, for example. Okay. Associations, I could say that they were normal or not. Just want to show you when you click the and go into the psychosis field if she's not psychotic, and you click this button, you get a nice paragraph denying any evidence of psychosis. If your patient is psychotic or has borderline psychotic features, you can go into the C list. Let me just preview what we have in here. You can say psychosis or borderline psychotic features are present. You can talk about abnormal behaviors, hallucinations, inappropriate affects, she delusional, and associations are listed here also. Everything from intact all the way down to word salad or untestable. Just as an aside for prescribing clinicians, if your patient, this is really more appropriate to a progress note, but still, if your patient has been on, say, Zyprexa or Risperdal, and for a couple of days, and you might want to say to them, how are the voices treating you? You can make custom buttons based on what your patients might answer in that situation. I'm going to click one here. It says, for example, auditory hallucinations are described as quote unquote from Blythe in the background now. Now I'm going to erase that because this is an initial assessment and probably her voices are right up front and center if she's experiencing them on admission. Okay. Suicidality, I'm just going to come in here to the C list and say she has ideas but no intention. And I'm going to say that her denial is, however, to me, not convincing. We're going to come over here. She's not homicidal. We have a mini mental status exam. All those questions that you like to ask patients. You can detail those pretty nicely in here. It's a nice shrub area. You can also come in here and talk about dementia. If she's having problems with cognition or dementia and you want to break that down, you can go into the C list here as well. Can she do a simple calculation? How is she with abstract proverbs? She oriented times 4 or not? Are there word retrieval, memory loss? Is she confused? What's her LOC when you're interviewing her today? If she's cognitively intact, I'm just going to click the normal button here. Once again, you get a nice paragraph. Okay. Her IQ, NI stands for normal intelligence. We'll just pop that in. Insight into her illness, good, fair, poor. I'm going to say it's poor. I'm also going to say her social judgment is poor. She has signs of anxiety. If I wanted to detail them, I could go into the C list. Her attention span is short and distracted. She's hyperactive. Her behavior is, once again, intrusive. If she's withdrawing from drugs or alcohol, we have a C list that you can explore here. You can talk about signs of withdrawal, signs of intoxication. If your patient's going into DTs or in DTs actively, you could document that here as well. Now, my patient doesn't have any of these, and the program's put in some opening sentences, so I'm just going to come in here, right-click, and cut those out, just to show you that I can do that. You can do a physical examination. Psychiatrists typically don't do that, but this is where a medical doctor would do after they did the medical history under the history of present illness. So the program can be used as just a straight medical H&P, skipping over the psychiatric prompts. You can come in and do an Ames exam when you open this up if you need to get a baseline. It shows normal, but you can detail it and you can print it out and it will go, you can click the green button here and it will show in your mental status exam. Nurses in the program also have Nurses in the program also have access to the AIMS exam. Constitutional vital signs. I made a little button here just to separate my vital signs from my mental status exam. If somebody else on your team has already captured vital signs today on this patient, maybe a tech or the nurse or the intake team or what have you, when you click this button, use previous vital signs from today, they're going to display here, and you're going to be able to push them right into here, so you don't have to redocument a set of vital signs that have already been captured by somebody else on the team. Since we're the first person in this chart, I'm just going to, in this note today, I'm just going to pop in something here really quick. And 14. The one thing I do want to tell you about this constitutional exam field, anything that you capture in here, you can do pulse oximetry if you want to. You can do a height, weight, BMI. I'm just going to do this really quickly. It's nice because all data in this field will show in your compiled note. It's also going to push out to your log tab where you're going to be able to trend each one of these individual results over time. So you can keep an eye on that BMI, for example. Fasting blood glucose, it was 145. If you want to talk about the A1C, what's going on with it today on admission, 5.2, you can do that. When I click done, this information is now in your note. And once again, the nurses also, if you were the first one to put in vital signs and they go in to do a nursing note after you've captured this information, they will be able to use the vital signs that you used. Vital signs clear out midnight every day for each patient. Okay, you don't need to worry about this. This is just telling us that we went through the mental status exam. We can see that by each of the little red X's here. We also have a musculoskeletal exam if you need to break this down. I'm just going to say all normal for this patient and go back. Okay. We're going to come over here to finish initial. Okay. We're going to train on the medication workflow in ICANotes in a separate training video. This training video is specific to capturing the clinical information. We'll come back and talk about entering medications, doing a clinical order sheet, and doing medication reconciliation in a separate training video. So let's just ignore this for right now. We're going to come over here to instructions, recommendations, and plans. I have custom buttons that work with this area. I can expand this whole field here by clicking right here. Now you can see all my custom buttons. These are all hardwired buttons that you're free to use. We're in an inpatient setting, so I'm going to say I'm seeing this patient in a psychiatric facility, and I'm going to say we're doing crisis-focused therapy, and maybe you're going to be doing some cognitive therapy on the patient coming up. You're going to be doing psychopharmacology. Whoops. I actually like to push that down to the next column here. You want this patient to participate in all activities on the unit. And I have a bunch of custom buttons here. Maybe you had entered medications on your initial note here and you want to talk to the patient about the risks and benefits of medication. So this is a custom button that I just popped in. There's all sorts of things you can push in here. We're going to go back. Your instructions recommendations show here. Psychiatrists, nurse practitioners, physician assistants, you don't have to put in a start and stop time. Your note is based on the level of detail that you've documented across here under evaluation and management. Now you can put down the stop and start time, but you're not obligated to. The only time you need to do that is when you're doing a psychotherapy note, and we're not doing that in this particular note today. Pink fields, medical history, notes, and risk factors. The program has captured information from these prior tabs and pushed important information out here. It's going to go forward into all future notes and be shared by all clinicians. I just want to show you that you can type in additional details. Give me just a minute here to tweak this. And I'm actually going to change the color of this so we can find it on our compiled note pretty easily for a training workflow. Okay. We do have a suicide and violence risk assessment. It shares a field with psychotherapy. I'm going to erase that heading and come over here. What are the history of risk factors? I'm going to say this patient has a history of suicide attempts of high lethality. And the number of the suicide attempts has been 3. And what current risk factors does she have? She has current suicide and violence risk factors, including borderline personality, financial difficulties, public humiliation, and suicidal ideas. No suicidal plan. Protective factors, I'm going to say her responsibility to her family and friends and her therapeutic relationship to you. Then you can come down here and say her risk of a suicide for right now is medium and her risk of violence is absent or very low. So you have a really nice suicide and violence risk assessment here. We can go back. We're ready to come up here into diagnoses. You can click this enter button to expand this field and work in it. Okay. In settings and directories, in the chart room, you can set up your own short list of your favorite ICD-10 codes, and that way you won't have to work through the filtering system that's built into ICANotes. So I have actually come over here and it says, when I clicked ICD-10 shortlist, this tab, it says select from your shortlist. Let me just show you what this can look like. So these are diagnoses that I personally put in, and I'm just going to come here with major depressive disorder, recurrent severe with psychotic symptoms as my first one. And then I can maybe put down a medical diagnosis. I think I have diabetes in here someplace. How about epilepsy? Okay. So you can put in as many as you want. You can reorder these. I want this to be number 1 and this to be number 2, but if for some reason she has a terrible epileptic seizure on the unit tonight and you feel that this is like really her most high risk issue right now, on tomorrow's progress note you could reorder this and put the epilepsy at top and the psychiatric disorders down below that if you want to. By default, all diagnoses you put in are active. They can be changed moving forward in the program to a different status. Also, if you wanted to make any diagnosis in here provisional, you could turn it into put an X here and it would say rule out major depressive disorder, but I'm not going to do that. Let's just look at how to enter an ICD-10 diagnosis in really quickly. You filtered it back 3 ways. I'm going to come down here to the F codes, mental, behavioral, neurodevelopmental disorders. And then I'm going to come over here and I'm looking for an anxiety disorder, for example. And then of course we have, I want to say a zillion, but there's a lot of anxiety disorders. I'm just going to come over here, agoraphobia with panic, for example. And that would be your 3rd disorder. If you wanted to make that a rule out, you could do that. And we click done. And, well, that's very interesting. It put the agoraphobia on top. Let me go back and look at that. Oh, it's because I didn't put number 3 after it. I see. Once you enter in it's very interesting. I put in 1 and 2 here, I left this blank, so it by default put this right at the top. Let's see if this changes here when I get in. Yes, it does. So now we have the depression, the epilepsy, and the agoraphobia. And notice the agoraphobia does have the little rule out here. Okay. To code your note, if you're using E&M coding, you just simply click this button, E&M code for me. If you want more information about how this is determined, please see our training videos on evaluation and management coding for the inpatient setting. This has given us a nice code of 99223. This is the highest code that you can generate for a complete psychiatric exam in the inpatient setting. You can see it really didn't take me too long, and I didn't have to go into meds to generate that code. I'm going to compile this note. Please don't leave training quite yet, because I have something very important to show you. We're in the complete evaluation by the psychiatrist. This is what your note looks like. Truly, you'll be able to do this in about 8 to 10 minutes in an inpatient setting. I didn't put any meds in. If you've built medication protocols, they'll pop in pretty quickly as well. We don't want you to do any changes to your compiled note other than a formatting change, like narrow this gap here, okay, or narrow this gap here, or put a period at the end of a sentence. But anything that's relative to the patient's care, please don't change here. Do not change your edit. Please do not make any change or edits here. They'll be lost if you go back into the work area. You have a signature line here. This note right now that we're looking at is not a legal document until it's electronically signed. E-signatures are handled here. This note has never been signed. You have the green light to sign it. Let's do that. As soon as I sign and lock it, that little icon there goes from gray to green. And I have an e-signature down here. Now, let's say that I've made a mistake in this note and I notice it after I've signed and locked the note. Because you own this note, or any note that you've created, you can go back into the work area and update the note, recompile it, and re-sign it. My mistake is right here. I put down history of cutting if anxious. That's not what the patient told me. What the patient really said was, I cut myself when I'm depressed. So, of course, I want to fix this immediately. If you wanted to go back in and put some test results that you just got back, or you wanted to tweak something in the social history or the family mental health history, you could do that. I've corrected this. I'm going to recompile. So what do we have here now? By the way, the reason you see a white flash on the screen is the program takes a picture of every note and saves it as a PDF, and it's accessible from our upload site. I'm no longer electronically signed in. There's a red X here, and you can see that my error has been corrected. I'm going to go ahead and re-sign the note. Here we go. Now when I scroll down, you can see that there's a new timestamp right here. This timestamp, if you can see it, oops, what I meant to do is this. This timestamp right here matches this timestamp, and it matches this timestamp. This is now a signed and locked document. You can always find your previous document. It's no longer in your active chart. The program stores up prior versions of this note in this field right here. Remember, in ICANotes, nothing ever goes away. It just gets out of your way. You could click on this link right here to preview that older version of the note. You can also do a comparison between note number 1 and note number 2 to see what the changes are. They're color-coded. This is a nice thing if you have an audit. The last thing I want to do is take you back to the chart face where we started. Here's our complete evaluation. Check mark means that it's signed. You can click on here and scroll down and read it. You can click on the compiled note, as can anybody working in your setting, to read it. Only you can go into the work area because you have the green stripe here to go back and tweak it now or anytime that you need to.